Good morning, everybody. Welcome to a Zoom meeting. I think this was the first for the Periop as a group. It didn't work out exactly the way I wanted to. I was hoping we could do this through the entire system, but we can't for technology reasons. But we have a workaround, thanks to Sarah Giancarcio. We are able to broadcast this to the ORs, and we're testing this today at RGH. And if it works well, we'll actually have about 60 mini conference rooms throughout the system that we can probably put anywhere from 4 to 8 people in, socially acceptable, and present conferences. More on that to come as we work this out. Today's conference is on revised COVID-19 protocols for the OR. First thing I want to talk about is safety. We've had safety in mind for us, our healthcare workers that work with us, and for our patients from the very beginning. We're now in our 12th week of this pandemic, and I have to congratulate everybody in that we really haven't had any problems. We have stuck together as a large surgical community across the system. We have been very strict with regards to PPE and protocols. We have treated every patient as if they were COVID positive. Now, after 12 weeks, we have learned a lot, and it's time to reevaluate our protocols and see where we can go. So that's the purpose of this meeting, but the thing I want to emphasize is safety. We want to be safe no matter what we do, and what I'm going to present today, errors on the conservative side for safety. You can find other areas that are a little bit more liberal, but until the data proves itself, we're going to be safe first. So starting with this, when we started looking at things, we went to the Anesthesia Society and the Anesthesia Patient Safety Foundation. And they had 3 principles to start with. The first is that all patients should be screened for symptoms prior to presenting to the hospital. That's part of our protocol, has been for the past 12 weeks. That includes not only temperature checks, but symptom checks and a variety of other things. This is also mandated by the New York State Department of Health, although we were doing this prior to the mandate. The second thing is because there was concern about testing with false positives. You've heard Dawn Reedy talk about a positive is definitely a positive, but a negative, well, maybe, maybe not. Maybe up to 30% of patients may be wrong on a false negative. That data is unclear. It was based on a small study. It's also very dependent upon how you test, whether you do a nasal test, a nasopharyngeal test, and so forth. We are using the strictest type testing. That's a nasopharyngeal. So any of you who've had that, you know what it feels like. It's been described as a brain biopsy. I personally have not had it, but I can imagine what it is. That is the most stringent way of doing it. We're not accepting nasal tests. So to know that the testing we're doing is probably the best that can be performed. And we're doing this on every patient that comes to the operating room, particularly elective patients, now that we're doing elective patients. We are doing droplet precautions. That's the standard PPE, the mask, the shields, gown, and gloves. Third thing that the society says that if a patient tests positive for SARS-CoV-2, then elective surgical procedures should be delayed until the patient is no longer infectious. And that's part of our protocol. Since we've gone to elective cases, we have said that if anybody who is an elective case is proven to be positive, then we will cancel them until they become negative. It's usually a 2-week quarantine followed by a negative test. And more of that as we get into this. So what's happening in the community? A lot of talk over the past 2 weeks that started this was at our colleagues across town at both Highland and at the university, that they weren't following the same rigors in protocol as we were. So we investigated. I have called colleagues over there on the surgical side. I asked Dr. Cortez to call the chair of anesthesia. And what we heard is that they had redefined their protocols in the operating room. They were using regular surgical masks, such as I have here. The use of N95s was very limited, and venting, well, quite frankly, they weren't venting for most of their cases. We didn't have the specific protocols, but the rumors we were hearing were true. I then engaged Dr. Lesko and Melissa Bronstein, talked to them about it, and then asked them to confer with their colleagues, because everything really has to be approved by them, both here and over there, their associates, and they did. And it was true that their protocols were different. So then we set out and tried to define, well, what are we going to do? So at this point, what I want to do is to tell you what's happening across the country, because there is no one set standard that everybody's adhering to. I have to give some kudos and more appreciation to the Department of Health of New York State, because overall their guidelines for the most part have been pretty good, although sometimes inconsistent on how they do it, or not, the way they implement it may not be the best, but the actual guidelines themselves, having reviewed what's going around the country, major centers, are pretty decent. So what's happening? If you go all the way to Hawaii, they're actually doing prior testing. We do it 3 days before. They can do it up to 5 days before. One of the interesting things that they do is they have a protocol for serial procedures, which interested me because of ECT. As you know, ECTs, they have them 3 a week. And how do we do that? Do we have to test them every time? And we adopted a policy here that they be tested once, and that was good for the week. And actually, Hawaii does the same thing. The medical centers there, they have one test that's valid for 7 days, and this would include anything, not only ECTs, but wound debridement or angiograms, followed by stenting or any other thing where you may have a serial episodes in the operating room. Houston, Texas, there's a large group, anesthesia group there that covers 4 or 5 hospitals. They're allowing testing up to 5 to 8 business days. So that's like 1.5 weeks. And I think if you're doing the testing we have and you're doing 8 days prior, I don't think that test is really very good. So I'm not sure how they develop that or what the logic is. But I'm showing this just to show you that the discrepancies across the country and what people are doing. Mayo Clinic in Minnesota, they have 3 branches, as you know, Minnesota, Arizona, and in Florida. For the group of hospitals that they have in Minnesota, they're pretty much the same as us. They test 2 days prior. They will accept a test for 1 week in circumstances, like someone has to go back to the OR, say, for a second time. They'll accept a test up to 1 week old if the patient is asymptomatic and has a negative interview test. Well, what is a negative interview test? It's actually something that we are doing presently and is mandated by the New York State Department of Health. And that negative interview test is the following. The patient has no fever, the symptoms has no symptoms, the patient hasn't had contact with someone who had COVID-19, or they themselves haven't had COVID-19 in the distant past. I don't have to read these for you, but this is stuff that we're already implementing. Mercy Hospital in St. Louis, to show you how you can really get very anal in how you want to break up your patients, came up with the next 6 charts. They broke their patients up to documentation of whether someone is COVID negative or positive, the testing procedure that they use, and the type of test that is given, what the patient is to wear, what the coworker is to wear, and then what you do for the room. And I'm not going to read this through you, but I present this only to show you on these slides is we did not want to create something this detailed, because I think it would be prohibitive to implement on a day-to-day basis for the staffing to do. So we wanted something very simple, a simple algorithm. North Shore is a collection of hospitals in Chicago. This is their algorithm. Partners in Health in Massachusetts, which includes MGH and affiliated hospitals. It's very interesting. They, for preoperative COVID testing, is not required for patients who are asymptomatic, do not have a high risk for COVID-19 infection, and will not be admitted to the hospital. In our system, that would be over half of our patients, probably greater than half of our patients, would not be COVID tested. So this is probably the most liberal that I have found across the country. Now you may say, how can they do that? Or what is it based on? I don't know. And the only science I can give you on this is that in our own asymptomatic patient group, Don Reedy looked at 5,000 who were tested going to surgery, and we found only 30 that were positive. And out of that, that's about a 0.6% rate. So the logic may be, maybe it costs us $250,000 to test that for that group. Maybe testing is not necessary if you follow this criteria. I don't know, but I'm just trying to show you the range of things that are being done to put it in perspective on what we're going to recommend doing. What I'd like to do is have Dr. Lesko come up and talk about diagnostic testing, since this is what we seem to be basing what we're going to propose, to go into a little more detail about this. Emil?
Thanks, Dr. Fanino. That was a very interesting and helpful overview of what's going on in the country. Can everybody hear me up there okay? And so we'll talk a little bit just for a couple of minutes about what goes on. And a little bit of the science here might help you try to understand why we say certain things or make some of the recommendations we do. So that's the virus, and those red things sticking out are the spike protein. And here at RRH, we're very fortunate to have a very robust lab presence. And at any given time, your patient's test could end up on one of 4 platforms. Not so much, but the one we started was the one on the bottom. That's the one that Dr. Walsh and Roberto and Don Reedy developed as an in-house. And for a long time, we were the community leaders in testing volume and implementing testing. Each one of these has a slightly different sensitivity. The specificity is pretty much the same throughout. And so, for example, a lot of the ones that are on the stat profiles go to the DiaSorin molecular platform. And there's no head-to-head comparisons. We've done head-to-head comparisons with bacterial analyzers, but not yet this. And in our experience, that's the least sensitive. So if I'm struggling with trying to get a patient back to a nurse, a long-term care facility, and they're negative, and then some test comes up with a positive, and they're negative, and it's 3 weeks, 4 weeks, we noticed that if you're tested on that platform, you're slightly more likely to be negative. Again, anecdotally experienced, no head-to-head studies. The BD Max we're seeing is probably the most sensitive. That's done at Elm Grove at ACM, along with the Roche. And Don's bringing the Roche here on site as well. And so this is a cartoon, but up on top there, any one of those platforms so quickly the virus was sequenced. When you have the sequence, you can look at the unique components that you can target to diagnose. And those things like the Roche, for example, looks at this open reading frame. Our in-house one looks at the N, a lot of them look at the S. And there's a lot of every platform has what's called an internal control. So we don't see that in Care Connect, but if you were to ask for the actual background report, you would see 2 values, all right? And so the one value is the actual reading of one of those targets. The other value is the control. This is how PCR goes. You take a RNA, make it into a DNA, break it down. You get your primers, and as it's annealing, as the sequences are matching, it's producing more of itself. It gets to a certain point, it cleaves off a reporter that fluoresces, and you detect it. And then what's actually reported is called a cycle threshold. This is all we see in Care Connect, but in the background, you can ask the lab and say, what was the cycle threshold? And if you think of that as the number of times the machine had to cycle through and amplify it in order to get that positive signal, you then know that it's inversely proportional to the viral load, if you will. So a cycle threshold somewhere up there around 30, has this many times less viral load than somebody down here, I'd say 12 or so. But behind this result here are two numbers, those S gene or the R gene numbers, that's the positive. So when that's more than 39, the test is called negative. But in order to fully call the test negative, the internal control has to be positive. The internal control is usually a ubiquitous gene that's found in all this type of virus, and that's what they use, and that's what you'll see sometimes as RP for RNA-dependent RNA polymerase, or some proprietary version. If that is not positive and the target is negative, it's an invalid test, and our lab won't even report it. So that's your first safeguard against the false negative test. What that tells you is that if the internal control is negative, there was something bad that happened in the test tube, and the reaction conditions didn't go, or there wasn't enough sample, there wasn't enough target to begin with. So, and that's how that goes. And so you say, well, what's the false negative rate? And the only true answer is we don't know, because there's no gold standard. But we soon may know now that validated antibody screenings are now available. But the big thing is you'd like to do is culture it, and it's very dangerous to culture. Almost no lab has the culture, only 3 or 4, so you can't culture it. So you can't say truly false negative, false positive. We say 30% false negative. I think that's based on 1 or 2 reports, and it's dependent on the sample. Was it a nasal sample? Was it a nasopharyngeal sample? Was it a throat sample? Was it a BAL sample? I think that's high. I give the test, especially the test here, a lot more credit than that. And just a guess, I'd say only about 10% false negative rate. You combine a negative test with the internal control that's positive, like I said, and a patient with negative symptoms, and you have a pretty low likelihood of, a post-test probability of having a patient with at least an infectious, if not no infection at all. So, if the patient's infectious, highly infectious, they probably have some type of positive test. Now, the false negative rate, and that was the basis of what was done for a while in the OR. The other thing you can have is for a false negative rate, so you can have a bad sample, somebody couldn't get up the nose well, or you could have a genetic mutation so that that primer can't sit down, and these are the bigger clades of SARS-CoV-2 across the world. And so you might have a mutation there. So to RRH's credit, this is amazing. So you're up to now over 33,000 tests. This is available on the daily dashboard, and you see the percent positives. You could see the number of employees positive there, and that's the current snapshot as of yesterday. And we started out, about 10%. And then we started out lower than that, and then about 10%. We're still holding about 10% positive. So when you see the numbers of tests going up, and you say, well, how are they talking about reopening? Our metrics are still favorable in that the percent positive has not gone up, even though the number of tests has gone up. The overall the daily new hospitalizations and new levels to the ICU have not gone up, even though it looks like some of them are accumulating because of the input that we're receiving from the nursing home. So I have to go up to B7 now. So if I'll just take a second or two in case somebody has a specific question about testing, I'll try to answer. All right, thank you.
Thank you. So let's move on now to what these new protocols that go into effect today. First of all, they're based on 3 principles of how we feel that this COVID is spread. One is direct human to human, which is why we wear a mask and try to keep socially distanced, because the virus can spread as we talk or as we cough or whatever. Contaminated surfaces, that's where someone coughs or touches someone who is infected, leaves the virus on a surface. We may go up and inadvertently touch it with our hands and then touch our face. It's amazing how many times we touch our face. They've done studies. It's hundreds, if not thousands of times during the day. Try making yourself not touch your face. So that's why the hand washing, and the droplet precautions. These first two methods are definite. There is no doubt that that's how it's spread. Aerosolizing procedures is theoretical. I don't know of anything that I've come across that says that absolutely it is spread through aerosolizing procedures, but it just makes sense from it. So it's an aerosolizing procedure on an infected patient can create droplets that can travel up to 1 meter. So with these three things in mind, we have come up with the following guidelines at this time. And again, this is subject to change. Every place that I looked at, the list that I gave you was as of the beginning or middle of May of this year. But every one of those sites had mentioned that this could change, and it was evolving as they got more and more knowledge, and it'll be the same for us. So what we're saying today most likely will change in the future as we become more knowledgeable about this disease. I want to start with, there are three things: COVID status, the type of procedure, the surgical procedure, the anesthesia. Those three things then will determine what type of masking is recommended for anesthesia, for the surgical staff, and then whether we vent the room or not. So right now, if we look at COVID negative patients undergoing a non-aerosolizing surgery, and the anesthesia can be would be general, it is recommended that anesthesia use an N95 for intubation and extubation. Actually, it's not recommended, I should say. We want you to do that for your safety. For people in the operating room, they do not have to wear an N95. They can wear a regular surgical mask. This is pretty much what they're doing at Strong now. I say optional N95 is because we have staff that may not feel comfortable right now without an N95. Okay, if you're not comfortable, you can wear an N95. We don't want to force people to do it. I know a lot of people, a lot of surgeons don't like to wear the N95s when they operate, so it's up to them. So we're making this optional, and no, we do not have to vent the room. Similarly, if a patient's COVID negative, non-aerosolizing procedure under a MAC regional or local, for anesthesia, this becomes an optional N95 because they're not doing anything on the airway that can produce aerosolization. Staff, again, it's optional, and we do not have to vent the room. Okay. The next two are COVID negative patients who are undergoing an aerosolizing surgical procedure, and regardless of whether it's general, MAC, regional, or local, we are requiring an N95 mask for anesthesia, N95 mask for the staff, and yes, we will vent the room. The next category is a replication of the first four that we did, and this is with a COVID positive patient. So COVID positive patients, whether they're having a non-aerosolizing or an aerosolizing procedure, regardless of the anesthesia, N95 masks are required for both anesthesia and the staff. Rooms have to be vented, and in this case, the patients will be recovered in the operating room and then returned directly to their room on the floor or in the ICU. So putting this all together and trying to keep it simple, the top two lines, if you're COVID negative and undergoing a non-aerosolizing procedure, we do not have to vent the rooms. In any case where a patient is COVID positive or undergoing an aerosolizing procedure, it is required that anesthesia and the staff wear an N95 mask and the room be vented. And in the case where the patient is COVID positive, the bottom four, the patient will be recovered in the operating room. We think this is safe. This has been through various iterations of groups involving chairs of all the major services, surgical services, anesthesia, and perioperative nursing. We've done this through a couple of different levels. It was also presented and approved by Incident Command yesterday, and this will take effect today at all our institutions throughout the system. A couple of caveats, which is just part of the recommendations, but most of these we're already doing. Elective cases special guidance. This basically is saying that if a patient tests positive, COVID positive, that the elective case will be canceled. Patient will be quarantined, referred to their primary care doctor for further treatment. Once they become negative, then they have to undergo a test 3 days beforehand and go through the cycle. For urgent and emergent cases, if waiting for the result of a COVID-19 test will cause negative outcomes for patients, patient should assume to be COVID positive, and a pre-op COVID test should be performed and the procedure to proceed. We do not want any life-threatening procedure to be delayed waiting for a test. If a patient is urgent, may have come in through the emergency room and has an urgent, maybe has a questionable appendicitis or something equivalent, and there is no harm by waiting the 4 hours, because now the testing has gotten much better. They're done at every hospital that we have. And if it can wait that 4 hours, the recommendation is you wait to see what the result of the test is and then proceed accordingly. Special situations. All upper GI procedures are considered aerosolizing. I don't think there is any debate on that. Lower GI procedures, colonoscopy, sigmoidoscopy, there has been a lot of controversy. We are considering these aerosolizing procedures until proven otherwise. I should note the university has the same stance. Both upper and lower are considered aerosolizing. So it's almost a community standard at this point, if you would. Procedures requiring a Bovie device will also require a smoke evacuator in the OR during use. Presently, we're in the midst of ordering enough smoke evacuators so every operating room in our system has a smoke evacuator. This is something that I know a lot of my colleagues are not crazy about, because ergonomically, they're not as facile as using the regular Bovie pen. But this is something that has been shown, particularly for those who use Bovie at a very high level, that you can have particle debris thrown up into the air, and that could be a danger. There are many states, and I'm sure New York State is in the process within the next year, that are going to mandate this for ORs, and this was even before COVID started. For laparoscopic procedures, there has been, although there has been nothing to confirm, but that when the gas is released from doing a laparoscopic procedure, there could be things harmful in the air. SAGES and the American College of Surgeons and a lot of major groups feel that there should be caution carried out when this is done. And the recommendation, and it's very simple, is to put a filter so things are evacuated either into a Neptune or into a smoke evacuator. These are in the process. If not available now, they are available in all the hospitals. We want to make sure they're available in the quantities that are needed going forward. And then finally, ECT procedures. These are only performed at RGH. So this was a source of a lot of conversation, let us say, on how these are done. This is really up to anesthesia at RGH. And the protocol that they use, they feel, is a non-aerosolizing protocol for anesthesia. It is not similar to doing an intubation. If they're going to be intubated, it's a different story. Most of these are not. After discussion with Emil and Melissa, it is felt that these will be done for safety for people wearing N95s, but the rooms do not have to be vented. And at this point, I will open it up to questions. I'll take one or two now if there are any, and if not, I'm going to turn this over to Dr. Tripp, who has a few announcements to make, and then we'll come back to more questions at the end. Lauren, are there any questions? Okay. Bob?
Good morning, everybody. So what I'm going to cover now is old news. This is what our protocol has been, but there continues to be some individuals that don't understand and aren't adhering to our, you want to go to the next slide there, Lauren? Oh, sorry. And that's the preoperative documentation, particularly of H&Ps, and I'll cover consents as well. This is a JCO requirement that I'm going to show you. It's talks about responsibility, namely of the surgeons, but we are asking our nursing staff to verify that it gets done before the patients are brought back to the operating room. We'll cover consents, and there is a little change with the COVID. We've enacted that, so there's nothing new today. H&Ps, they must be completed within 30 days of the procedure. So elective procedures coming in the day of surgery have a full H&P the day of the procedure. This can be by any physician or APP or SPT people. If the patient's admitted, they must have it within 24 hours, and certainly must have it before they go to the operating room. If there is a true emergency where we can't wait, then that's an exception. Same with consents, but that's a very rare thing. The H&P must be updated the day of surgery. It's called an interval H&P update. There is, and that has to be done by attending. It can't be agree with the above. It can't be a PA signing it in lieu of the attending. It has to be the attending surgeon that signs that interval H&P update. I'll show you examples of that for people to understand. There are minimum requirements, as noted. Again, this is the JCO's requirements. That's not RGH's or RRH's, but it's the JCO, and we need to be in compliance with that. And there is an interval update there on E. You can see there's an interval update template in CareConnect. The nurses don't need to worry about that portion, but you can educate your doctors if they're giving you a hard time. There's an easy way to do this. It's called a smart phrase. At RGH, we use the dot update H&P. When the doctor clicks that, it says RGH OR internal H&P. And then the next two lines there is what comes up when you click on that. When you go F2, it'll show that, and then you'll see in the chart, I performed a focused examination of the patient prior to the procedure, reviewed and agree with the current history and physical, no changes noted. Or if there is a change, then the second line there says there's the following changes, and the doctor has to fill in those changes. But the bottom line is the note by the physician has to state that they performed the focused examination. If I have a hernia patient, it means I've checked the hernia site, I've verified that, and there are no changes. There's no changes in the patient's history. They didn't come down with COVID in the meantime. They didn't have a heart attack. Whatever's happened in that interval, I need to document. Again, it's not your responsibility as nurses to verify the documentation other than the doctor has made this statement and signed it. Again, it can't be agree with above. It has to be the doctor's official note. We'll skip over this. This was if we did the total system-wide thing, and that was Unity has a little different smart phrase. It's a little more complex, but the same thing. It says that they've documented and reviewed the history physical, and there are or are not changes. So again, to let people know what your responsibilities are, and this is, again, is no change. You need an interval update the day of surgery. It needs to be by the attending. It has the following requirements. Again, it's automated if you use the dot phrase. The other thing that needs to be done is the informed consent needs to be completed. That needs to be done by the anesthesiologist as well. All of this needs to be completed before going into the operating room. Can't be that the doctor says, I'm going to do it in a minute, just go ahead, and then you find out they didn't do it. It has to be done before they go to the OR. Again, JCO requirement, we've audited this, and there's a number of times where the doctors aren't doing it, and the nurses aren't verifying that, they're just taking them in. So please do the above. If anybody's giving you a hard time, let me know, let your chief of the other departments know, and we will support you. This is a requirement. Michelle and Sarah have been doing audits as well, so everybody will be held accountable. Briefly on informed consents, this talks about the requirements, what you need to do, that we have, this is JCO requirements, that there needs to be an informed consent covering the risks, the benefits, and the alternatives, and that needs to be documented in the chart. It needs to be on paper. Eventually we'll have it in the chart. I say it needs to be on paper. The paper can actually be scanned into the chart. Eventually we'll have signing of the materials in the record, not actually a piece of paper, and you'll look in the record for it, but it needs to be a completed form that has those statements. It needs to be signed by the physician, again, not the APPs or other people, they can sign it, they can get it, but it has to be co-signed by the physician, has to be dated and timed, has to be within 30 days of the operation, and it can be updated the day of the procedure if it's greater than 30 days. Again, it needs to be in there prior to going to the operating room. With the COVID, we do have a change in that we have verbal consents. Same rules, okay? The surgeon still has to have the piece of paper, the consent, you sign it, you date it, you time it. You state on there, instead of the patient signing it, that it's a verbal consent by the patient. And then the surgeon is supposed to use a smart phrase, needs to use a smart phrase in the chart. Again, the staff need to verify that that's been done. The docs have all been given these dot phrases. There's one for surgery, there's one for anesthesia, and there's one for blood. Blood is incorporated into the surgical consent. We don't need a separate one if we're giving blood in the operating room, but for nurses on the floors, that's a separate consent. Again, there's an example of the surgical one, a little lengthy, but it's just a dot phrase, so it's very easy for the surgeon to enact, for the anesthesiologist to enact in there, but you should see that in the patient's chart with their updated interval H&P. Fairly straightforward, but we need to adhere to that. There have been some incidents where people didn't do that recently, and we've had some quality issues. Most of these requirements aren't just to keep people busy, it's for patient care quality. We need to maintain that as best we can. Any questions anybody has? Lauren, anything? So certainly if anybody has any questions about any of this, they can ask myself, Dominic, Ralph in the operating room. Kevin Casey's here in the room with us. Again, all social distancing, nobody's within 20 feet of each other. But please ask any of us any questions, and we'll keep handling all the changes that come through and maintain the high quality of patient care and the safety of all our staff, as well as our patients. Thank you.
In the time remaining, are there any questions? Questions can be asked through, is there a chat? We have a few questions here to answer.
So the first one is from Maureen Harris. There have been some patients that are consistently testing positive and they're asymptomatic. Is there a process to clear the patient for surgery if still positive but asymptomatic for more than 3 to 4 weeks? Are they to be handled as a positive or should they have an ID conflict?
So Dr. Medeiros asked about a patient who is continuously test positive. I'm sorry? But is asymptomatic, and what to do with that patient. Well, unless they're going to have an urgent or emergent condition that needs to be done, if they do have something that's urgent, and if it's from Dr. Medeiros and it's a cancer, and it gets to the point where this is going on, as she mentioned, for a couple of weeks, I think that person then probably would have to be done and be considered a PUI, because if it's a positive test, as we have heard, you're positive. So even though they're not symptomatic, I think it has to be treated as a PUI, and they could go forward. If it's not an urgent situation and there is no resolution with primary care, then I think it would be wise to go to an infectious disease physician to find out what's the best way of treating that.
And then the second one's for Dr. Tripp.
Question for Dr. Tripp.
If an APP gets a consent, does it have to be co-signed prior to entering the OR or co-signed the day of the OR?
The APPs can get consents, that's okay. The surgeon needs to document that they've discussed the risks and benefits of the procedure with the patient, and they need to co-sign that consent. They need to time and date it. It has to be co-signed prior to going to the operating room. It can be the day they get the consent, can't be more than 30 days old, or they have to co-sign that note. But it absolutely has to be co-signed by the surgeon, timed and dated, prior to going to the operating room.
So, Dr. Roberts at the point saying that the 30-day rule isn't really a rule for consents. That it's according to compliance now.
I think it's the JCO rule, not a Department of Health rule. I think it's a JCO rule, Joint Commission rule, not a Department of Health. So don't forget, we're regulated by multiple bodies.
And my understanding isn't, my understanding is same as Ralph's with the caveat with what Paul's bringing up. If the patient signed it 2 months ago and you document nothing's changed, consent still applies, the doctor documents that they've talked to the patient, it still applies, but they have to re-sign it within 30 days. So the day of the procedure, they should re-sign that consent so that it's within 30 days.
Frank Solomon asks, smoke evacuator bogey doesn't fit into the mouth, for example, for tonsillectomy. What do you do in this situation?
Dr. Salamone had a very good question on smoke evacuator with a bovie doesn't fit into the mouth. Frank, I think what you can do is look into what we do with CO2 laser surgery in the sense that we have a freestanding smoke evacuator, and that has various nozzles or tips so you can evacuate from the side. They're powerful enough to suck the air out. And I can tell you that I would treat it that way, so you would still be in compliance of everything.
It would be considered aerosolized procedure.
Yes.
So you're going to wear N95s.
Right.
Another issue came up where a patient was tested 4 days out and was here for their procedure. As long as they were negative, I told them to get another test and just proceed with the procedure.
So the question was from Dr. Cortez, patient was 4 days out. The patient was tested negative, came in, and what they did at the day of surgery was proceed with the surgery but get another test beforehand. I think the next stage may be something similar to what the Mayo Clinic did. And what the Mayo Clinic did, if you have someone like that, the Mayo Clinic, if they're within a week of the test and they go through that rigid criteria of the negative on the questions asked, and we're doing that, maybe we're not doing it as rigorous as the Mayo is doing it, going into in-depth detail about who they're living with and things like that. But that would be maybe the next modification of this so we don't have to retest. But for now, I think that's appropriate.
According to state, you got to retest, but you don't have to, you don't necessarily have to wait.
Right. That's correct. That's correct. Lauren, any other questions? Okay, I want to thank everybody. If there are any questions, feel free to text or email me, and I will get back with you. And have a good day. Thank you.